Okay, great. Hey, thanks, Lisa, and welcome everyone to the webinar. As you heard, I'm a dental technician. I have been in implant restorative since about the late 80s. I worked in as an in-house technician in a group practice in Salt Lake City, and then joined on with Attachments International in 1990, and then have been with Implant Direct for about the last 5 years. And tonight's presentation, we're going to kind of cover one of the early innovations of all-in-one packaging with multi-purpose fixture mounts that can be used as a transfer and as a possible abutment. And our objectives, as you can see, are the understanding the various uses and applications of those multi-purpose fixture mounts, the clinical as well as laboratory procedures, situations where the might not be able to use the multi-purpose fixture mounts and where you'd want to consider a custom abutment. So here you can see the all-in-one packaging with the multi-purpose fixture mounts. So you can see the Legacy 3 has an abutment that's more indicated for a final fixed cemented crown. You can see the Legacy 2 multi-purpose fixture mount is more indicated for a temporary restoration. And also included in the packaging is the cover screw and the little extender that can be used as a healing cap. So as we'll show that these fixture mounts can also be used later as for a closed tray impression with the shorter screw, or you can use this long screw for an open tray impression later on. Kind of have a video to kind of show how the packaging comes together. So you can see the little cover screw and extender is in the bottom. You can take that out, decide if you're going to do 1 or 2 stage surgery, if you want to close the tissue. So the top portion can be removed for an abutment, then the cover screw and extender are applied as shown. Okay, here's an example from Dr. De Oliveira where he's placing the implant, and then later on using that multi-purpose fixture mount for a closed tray impression. You would just block out the access hole, of course, with some wax or maybe Teflon tape. Here's another one of Dr. August's cases with the 4.5 platform. Okay, so it's in place. So he now removes the fixture mount, removes this top portion. Then you can see he did some little extra preparation on the margin here to lower that down a bit. Then he air abraded the fixture mount, which is now going to be the abutment. And then he's a big CEREC user in the office, so he's going to scan it and then make a little provisional with this CEREC unit, kind of out of occlusion. Then later on, he makes the final abutment in occlusion fitting over the fixture mount. All-in-one packaging kind of simplifies your ordering because you have a possible impression transfer and abutment all in one. Here's another case example from Dr. O'Brien out of Glendale, California. He's using our large Legacy, the 7mm body implant. It has a more extreme platform shift where it has a 5.7 restorative platform, but the body's 7, so you can see how it tapers in. And the Legacy 2 fixture mount was more designed for provisionals, but in this case, Dr. O'Brien's actually going to use it also, not only for the provisional, but also for the final abutment. So you can see how, in this case, he removed the top portion of the fixture mount, and he elected to do immediate loading on this case. So you can see how he kind of moved the tissue forward. Then he formed acrylic around the bottom portion of the fixture mount, and now it's going to be a screw-retained provisional. And then 3 months later, the patient comes back, and now he did a little more prepping on that fixture mount, took a conventional impression, sent that off to the lab, so you can see it's just pretty much conventional crown and bridge here for cemented crown. So here we are intraoral with the cemented crown. So that's the Legacy 2 fixture mount. Here's a Legacy 3 that has a kind of a beefier abutment for the final restoration. You see how the packaging works here. There are some manufacturers that don't even include a cover screw with the implant. So that can be an issue if your chair side place the implant, you don't even have the cover screw that has to be ordered separately. Here it's included as well as an extender. Here's another nice example from Dr. O'Brien where he's doing a full arch case. He's going to start it out like it's going to be a denture case for the mounting, but then he's going to turn this into a cemented crown and bridge case. But it starts out as a denture case. So we have our denture wax try-in, and it's a good idea to get in the habit of taking these side profile photos, the lips in repose, high smile line, and the labs technicians love getting these photos to be a part of it, to have their input on the case. Okay, so now Dr. O'Brien's going to do the 3D planning, doing a cone beam in a virtual software. So he just applies some radio-opaque dye-cal on the cervicals of these denture teeth and also on the occlusals. Then the patient will wear this during the cone beam scan. Okay, and then this shows the software called Anatomage, and we teach this. We actually have a 3D course, 3D implantology course here at the Educational Center in Vegas, and you get to learn how to run this software. So you can see how you can do the cross-sectional views to see if you have sufficient bone surrounding the implant. You can measure if you have at least 2 millimeters of space above the nerve. You can see if you have adequate room in between the implants. You can see the trajectory of the implants, so you can decide if you're going to need to use an angled abutment. And then you can see if the implants are emerging right through the centers of the crowns as desired. Kind of roll that around. Here we can see from the dye-cal on the cervicals that the trajectory of the implant is not going to protrude through the facial of the implants. Then in the posterior, we can see the trajectory is right through the centers where we want them. Very nice. So any changes can be made here in advance before the implants are placed, because in dentistry we don't like surprises. We want to know in advance how everything's going to turn out. So here's the drilling guides. So once that was completed, he sends that off to Anatomage, and they made the drilling guides. And in this case, he's just using what's called pilot guides. And on pilot guides, they're just for the initial, our 2.3 initial pilot burr, because that's the most important osteotomy. Because with Implant Direct, we use step drills, so the succeeding drill follows the previous drill. So after Dr. O'Brien does the osteotomies with the 2.3, he'll remove these guides and finish the osteotomies freehand with these step drills. So here's placement, and then here's 3 months post-op. So you can see the nice placement. You can see they have nice thick ridge. I wish all lower ridges were this thick. So we have adequate bone surrounding the implant. Then we have even more than 3 millimeters interproximal in between the implants. You can see the direct implants are color coded, so you can tell that there's a 5.7 posterior, 2.45 platforms, and one 3.5 platform in the mesial. Okay, so now the doctor has the choice to use the fixture mounts now as an impression transfer or as just in a direct abutment. Dr. O'Brien usually just goes ahead and preps these at chairside, which is what he does in this case. Okay, so he has our little holder. We have this handy pin vise holder that holds any of our analogs, so that you can put this fixture mount or any other stock abutment into the analog, and so you have a holder. So you do this bulk preparation outside of the mouth, because you can imagine you wouldn't want to cut all these tops off intraorally. Okay, so the bulk preparation was down outside of the mouth, connected to this holder, and then you can see Dr. O'Brien used a laser so he doesn't have to pack cord, so he kind of separated here for the margins using a laser. So you can see from here out, it's going to be a pretty much just conventional crown and bridge. You really don't even think of it as an implant case anymore. And the laboratory treats it as a conventional case. You just decide if you want to do single units or bridges. Dr. O'Brien in this case is going to do bridges, and he just made some indexes and had the lab make some provisionals from indexes made from those denture setups. So these provisionals are going to line right up where the denture teeth were in the try-ins. So here's the provisionals, just like in the same orientation as the dentures. Looks very nice. So here's the final bridge in the lab on the model. So you can see a pretty much conventional crown and bridge case. In this case, Dr. O'Brien elected to use our little PDC keyway attachment to tie it all together. So the upper bridge was made in 3 sections and tied together with these little keyway attachments. That's optional. That's not mandatory procedure there. So you can see it's a pretty much conventional crown and bridge. So the crown and bridge is also in the same orientation as the denture teeth. So an index was made, and so that helps guide the crown and bridge technician on orienting his ceramics. Again, so there's no surprises. When it's all finished, we know how it's going to look. We know that we're not going to affect the patient's phonetics or any problems in that regard. So very nicely done. Here's an interesting case from Dr. Winokur in New York, where he's going to actually use the natural tooth as the provisional. He's going to form this clinical crown of the natural tooth over the fixture mount. So you can see it had a root fracture, so this tooth had to go. Here's our Legacy 2 that has that same fixture mount we saw previously. So you can see he hollowed out that natural tooth, and it's going to fit it around the Legacy 2 fixture mount as the provisional with some composite here. See how nice that looks? And so now so it's going to be immediate loading. He'll make sure it's out of occlusion, but you can see how now the tissue is going to heal to this natural tooth provisional. So we'll have a nice natural emergence profile. So here we have 3 months later, see how nice this tissue looks, that it's healed to that same natural tooth. No changes there. So now's time for impressions, but when you remove the provisional, look what happens to the tissue. The tissue collapsed. We don't want to take an impression of collapsed tissue and send that to the lab. Okay, so he's going to customize another fixture mount to be the impression transfer. So he makes a little model with an implant analog in the model, screws down the provisional, then injects a little PVS material around that, removes the provisional, and then screws in the fixture mount. Okay, and then injects a little composite or acrylic around the fixture mount. So now this fixture mount is now going to be a custom transfer. So it's a customized transfer with the same emergence profile as that natural tooth. So this is in place. Do either open tray or closed tray impression, send that to the lab. So the lab will now be able to replicate that provisional in the final crown, so it has the same emergence. Very nice tissue response here. And we teach this technique in our 102 course here in Las Vegas at the Educational Center. Here's a little bit of the hands-on, where we have a little typodont model that represents the patient, where there's a kind of a wax-up, little silicone jig is made around that. Then you can see the top part of the fixture mount is removed. You fill in the access hole with some Teflon tape, inject in some bisacryl material, then apply your jig or stent. Then you remove the stent, kind of expose the access hole and remove the provisional. So you can see now the provisional's attached to that Legacy 2 fixture mount. This has been air abraded, and then some bonding agent is applied, and then you can just apply some flowable composite around that temporary under the provisional. So now you have a screwy tame provisional made around the Legacy 2 fixture mount. And then the other part of the hands-on is where you actually customize a fixture mount to be the custom impression tray, as shown in the previous case, where you do a little moulage around the provisional and make a customized impression transfer. Different case, happy patient. Okay, here's a nice case example from Dr. Tuttle out of Lake Elsinore, where she's going to do a full arch fixed detachable bridge. So here's, as you can see, the extractions. Then again, she's into the guided surgery with the, she also uses anatomage. And so this one's going to be fully guided. So you can see here's the guide in place, but this is fully guided. See, they're the wider cylinders. And so there's a handle kit that act as step downs for the different drill diameters. So all of the osteotomies are going to be performed with this guide in place using the handle kit. And on this case is going to be our interactive implant. which is a conical connection implant that has a 78 degree conical connection rather than the 45 degree for the legacy implant. And this fixture mount is a little bit different than the previous. This fixture mount has a little snap cap. So the little snap caps will actually snap off. You don't have to cut them off. They are actually pulled off in the impression. And here we can see the abutments. The crown and bridge abutments are only going to be used for the impression in this case, since the final restoration is going to be a screw-down hybrid denture bridge, so they're not going to be used for a crown and bridge case, but they will be used to transfer the analogs to the model. So here we can see the little snap caps were pulled off in the impression, and let's look at this video. I'll just kind of go through the video before we go any further here. So this shows the little snap cap, how it pulls off in the impression. So here's the packaging. So you can see it has a hex that engages inside of this crown and bridge abutment. They call this the square. It has our standard square for our ratchet or torque wrench. Then the bottom of this piece has a hex. Then you can see the little prongs that snap in. So this snaps together. And then this abutment can be reduced if needed for crown and bridge. It can be shortened. So here you can see that 78 degree lead-in bevel. That's what gives it why it's called the conical connection, makes a tighter seal between the prosthetics and the implant. I'm going to kind of jump ahead because we're really talking more prosthetics than implant. Here this talks about the features of the implant. This shows with the conical connection you have a more of an extreme emergence profile, more of a flared, I should say, more of a flared emergence profile through the tissue. We're just talking about the surgical protocol of the drilling. I'm going to kind of jump forward on this because we're not really talking surgery. So you go through the various sizes. So this is a 3/7 implant. So the final drill is going to be a 3/4. So there's a little parallel pin you can put in between. So in between the osteotomies, you can put in this little parallel pin to see how you're doing, to see if you have to make another adjustment if you're not doing guided surgery. Again, I'm going to kind of jump forward a little bit because the last drill is going to be for the 3/7 will be a 3/4. So this 3/4 drill is the last drill for the 3/7 implant. Okay, I'm going to kind of jump forward a little bit because we're not really talking about surgery. Okay, and then our vials also come with these little sticker labels, so you can put the little stickers in the patient's chart so that matches. So you want to look and make sure everything matches when you look at the label. Have that in the patient's chart. Okay, so it's now going to show you how you can use this. Now that was the fixture mount will be now used for the impression. So it can be removed from the square section with the torque wrench is one way of removing it. So this has a square, it has little prongs, so it has a friction fit. It also has a safety feature where it will break if you go past, I think it's like 160 newtons, so it doesn't do any damage to the implant. Or you can go directly into the abutment with a 2.3 hex driver. Okay, pick it up that way. So here it's going to be driven into the osteotomy. They're going to index the flat of the abutment. Okay, this is considered indexing, so the flat of this abutment will line up with the flat of the implant. That's what they call implant indexing. That helps when you're using stock abutments. It's not as critical if you're going to do custom abutments. You don't have to worry as much about the indexing because everything's customized. Okay, and if space is limited, you can take the 2.3 hex driver into the abutment itself without that little snap cap. Or you can remove that abutment and drive it at implant level directly with the 2.3 hex. Excuse me. Okay, so here now for the impression, some PBS material. a closed tray impression, but it gives the accuracy of an open tray impression because that snap cap pulls off in the impression as if it was an open tray. But as you can see here, this is just a closed tray impression, but you can see the little snap cap pulled off in the impression. So you could leave that abutment in if you're going to do immediate loading, or in this case, what they're going to do is remove the abutment and then place the little included extender with the little cover screw and extender. So you can see how that tissue is closed off. Okay, and for 2 stays, let's say you want to bury the implant, you wouldn't use the extender. You would just use the cover screw, and then this is what they call burying the implant. Sometimes you do that if you get, say, less than 20 newtons torque, or if the patient's diabetic or smoker, for some reason you want to bury it. Okay, then the laboratory will attach that abutment to an implant replica and now push it into the snap cap with the flat side to the facial. So indexing helps the laboratory technician in reinserting correctly that abutment attached to the implant analog correctly. So you can see the lab tech will put on a little soft tissue material, make what's called a soft tissue model. So there's that abutment that was part of the fixture mount. Then it can be shortened if needed, or if not, the lab tech will just wax out that little undercut. Here it shows, I think they're putting a little petroleum jelly around it. They'll block that out and then just make a coping and crown that fits over that. So when it's time for delivery, you just remove the cover screw and extender, seat what is now the abutment, and then torque that down. We recommend 30 newtons of torque with the torque. First, there's usually screwed in with finger pressure, and then a torque tip is applied. With Implant Direct, it's usually to 30 newtons for the prosthetics. Then you would block that out, most likely nowadays with Teflon tape, and then go ahead and cement your crown. Okay, so that's the interactive multi-purpose fixture mount. But in this case that we were showing from Dr. Tuttle, it's not going to be crown and bridge, but they'll use this crown and bridge type abutment to do the transfer for the model. Okay, so they attach an implant replica to the fixture mount, snap that back in the impression. So you can see the final restoration is a screw-down hybrid denture bridge. You can see these are non-engaging connections here in the framework that's under this hybrid bridge. Very top-notch aesthetics. Hopefully the patient can kind of get the super floss and the water pick through here for hygiene. So this is a screw-down dentist removable, not patient removable bridge. So the next case will again be the interactive with the 3.4 platform with the snap cap, but it'll be a crown and bridge case for a single unit bicuspid crown. In this case, instead of attaching to an implant replica, they're going to attach the fixture mount abutment to an abutment replica. So they're going to use this abutment. You can't see it. This abutment is kind of hollowed out, and the snap cap fits, or this also fits into the snap cap, this abutment analog. Okay, so you can see in the model, they use this abutment analog that snapped into the snap cap in the impression, so the lab had an abutment analog in the impression, which can be shortened if needed. Then they'll make what's called a reduction coping if necessary. So this has what's different here, using the abutment analog instead of an implant analog attached to the fixture mount. Okay, here's a nice case from Dr. McElroy that does a lot of CEREC. So he's going to use our fixture mounts and with his CEREC unit. And he also does the virtual planning with his Galileo system. So you can see drawing in the nerve, placing the implants, putting in virtual crowns. So now we see that the crown trajectories are all going to be right through the centers of the occlusals of the crowns, and all the spacing is ideal, and the distance from the nerve is ideal. And we know in advance how everything's going to line up. So here's, again, fully guided fixture guide that's going to rest on the natural teeth on the other side. So you can see it's going to be fully guided. Well, they use the little step-down handles. And then this hole just kind of exposes the natural tooth on this side, just so you can see that the drilling guide is fully seated. So here's the legacy implants in place with the two-piece extensions. We used a little cover screw and the extension. So here, now getting into the virtual design, have kind of a generic, have a generic virtual design with the 3 virtual crowns. But what Dr. McElroy elected to do in this case is go ahead and take an impression, make a conventional implant model with implant replicas in the model, a soft tissue model. Then he, again, removed the top section of the fixture mount, and now he's going to scan these abutments on the model. So the software is just going to think they're just regular preps. The software isn't going to know they're implants. Okay, so here's the virtual crown design. So you can see that the implants are directly right through the centers of the crowns. But what doctor elected to do is make these screw-retained crowns. So he's going to have the CEREC crowns cemented to the multi-purpose fixture mounts that have been altered using a composite resin cement. So here we have the stained and glazed crowns that are cemented to the Legacy 3 fixture mounts. So you can see the CEREC crown, and they do now have a CEREC material Emax, so it could be an Emax crown made with the CEREC unit, would be cemented over the stock abutment, or in this case cemented over the prepared multi-unit fixture mount. And using a composite resin cement, a common cement to use is from Ivoclar. They call it multi-link abutment cement. So it's an opaque cement so the abutment doesn't show through. So that's called multi-link abutment cement. So it's now cemented outside of the mouth. Try it on the model. So here we see the little CEREC units have been cemented to the multi-purpose fixture mounts, and then the advantage is the cement was performed outside of the mouth. We don't have to worry if we had any cement that can cause sepsis, kind of any cement sneaking under the abutments. So it's all done very cleanly. And there's been a big trend in going back, resorting back to screw-retained crowns and implants. Screw-retained crowns were big in the late 80s, early 90s. They kind of went away, everything was cemented, and now we're making a big resurgence back to screw-retained. Many doctors now are saying their restoration of choice nowadays is screw-retained. So you can see how the ceramic crown cemented to the stock abutment, and some doctors tell their labs to go ahead and cement the ceramic crowns in the lab. Other doctors say, well, just send the abutments separately. You'll try it in for your contacts and then cement them together in case you need any adjustment on the contacts. So you would torque down the screws to say your 30 newtons, twist in some Teflon tape, then patch that up with some composite. So you can't really even tell that these are screw-retained crowns. But it's a nice feature, say in the future, if the screw ever comes loose or if something breaks, you can unscrew this, get it out, put it back together without having to cut off a Emax crown, which is not so fun to do. Here's a similar case sample from Dr. Saab. He's another one of the speakers here at the Educational Center in Las Vegas. He teaches the 101 implants that focus on posteriors, and he also be teaching a full arch hybrid denture bridge course coming up later in the year. But in this case, he used the Legacy 4, the 7.0, And the 7.0 is the wide body implant that has more of the extreme platform shift that shifts down to the 5.7 platform. You can see that here. And the Legacy 4 abutments have kind of a concave collar, so a concave emergence profile. Turns out the tissue likes that for the tissue adaptation, likes this concave profile coming up through the tissue. So you can see they've been cemented together for a screw-retained molar crown. Here's another one of Dr. Saab's cases on a bicuspid, screw-retained bicuspid, again over the Legacy 3 fixture mount, screw-retained crown. Here's another case showing the Legacy 2 fixture mount from Dr. Hall out of Michigan, and he's a periodontist. He doesn't actually do the restorative, but what he uses this for is to make custom-made healing caps. So rather than using a little round healing cap, he'll form the healing cap with some composite or resin material around the fixture mount, so it'll have that nice natural emergence profile as the tissue will now heal to these customized healing caps. It'll have this emergence profile coming through the tissue. Then the customized healing caps can be used later on by the restoring doctor, again to do that same technique that was shown previously. In this case, you would make a little model with an implant replica and make an impression around the custom healing cap, and then put in the fixture mount or impression transfer, form some composite or resin around that. So now again you have a customized impression transfer that's going to have that same emergence profile. Okay, so now we're going to talk about customized abutment, because you can't always use the stock abutments. You can't always use the fixture mounts as is. Sometimes you want to control better the margin at the tissue or control the ferrule height. Sometimes you have an extreme difference between the interproximal margins and the facial margin, for example. So by controlling those margins, you control better the cement, so you don't have cement sneaking underneath the margins, which can create a sepsis problem, which will be what happens in this case example from Dr. Holden out of Canada. He placed the implant, put on a standard type healing cap. He just assumed that he would be restoring the case later, but then the patient showed up later with the crown. So he said, oh, you already have a crown. So he took an x-ray, but what did he find? Look at all this bone loss. So it's kind of implant peritonitis or bone loss, and that was believed to be caused by this cement. And some cements are more toxic than others, and some cements like this one are virtually invisible on the x-ray, so you really can't see all this cement. You can see gingival. Okay, not only that cement under the crown, but there was also a ring of cement here around the implant. So we removed this big glob of cement. Kind of cleaned everything up. So it's kind of a peri-implantitis, what I meant to say. So he kind of cleaned this up, made it bleed. I'm not sure if he used a laser. Some doctors use a laser. And then used something called chloramine T to kind of clean this up. Did the grafting, a membrane. Some doctors do the PRF tissue membrane. Close that up. So hopefully this graft will take. One technique that can be used to eliminate excess cement is where you have the final abutment, you put some plumber's tape, Teflon tape in the crown, push in the final abutment, take the final abutment out, and now inject in some PVS material. So you've made a little PVS die. Okay, so the PVS plumber's tape kind of stood in for the cement layer. Okay, so now you remove this, the plumber's tape, place your cement in the crown, and then use a little PVS die. So you push in the PVS die, wipe off the excess cement, but now when you pull out the PVS die, the cement remains in the crown. So now you don't have excess cement that's going to kind of sneak under the margin. So that's one technique. But if you make custom abutments where you have the controlled margins right where you need them, that you most likely won't have this issue of cement sneaking under the margin. Here's some samples that have caused some bone loss. As you can see, some cements are hard to see. This one you can see a little bit in the x-ray. Some of these cements aren't very radiopaque. In fact, a study was done, was it published in a perio journal, that showed that the least toxic cement was the old zinc phosphates. So the old zinc phosphates that are also radiopaque, and they were turned out to be the least toxic to the tissues and bones. Here's a cement sepsis sample given to me by Dr. Weberson. Dr. Weberson is also here in Las Vegas, and he also helps out with our 102 prosthetic course here in Las Vegas, and he also teaches at UNLV. But here's a case. Now, he didn't do this implant, but the case that showed up with a big glob of cement and all this bone loss. So we're attributing that to the cement sepsis. And you can see on a cone beam scan, you can see how much bone loss there actually was in the side view. So this implant had to be removed. Dr. Weberson did some grafting, and I'll have to check with him if that implant if the new implant has integrated yet. So you can see what that cement sepsis can really be a problem. So by using a custom abutment, you're going to avoid that type of issue. Here's a case example from Dr. De Oliveira using our fixture mount. But you can see the implant was pretty deep placement, so not much of the fixture mount left. So this is going to be a sample where they can maybe use the fixture mount for the impression transfer, but a custom abutment will be made in this case. Now, the traditional way of doing custom abutments is what's called a UCLA abutment, where that's an abutment that fits directly to the implant. Then the lab would have a model where they would wax around the UCLA abutment to make custom cast to UCLA abutments. Here they're casting to gold cylinders. And Attachments International actually made the very first UCLA abutment, and they were made for UCLA, actually at UCLA, Drs. Lewis and Dr. Bremer, so that's why it's called the UCLA abutment. And Attachments International actually made the very first ones back in the 80s. But one advantage that still remains for a cast to UCLA abutment is in a tight situation, the lab can put opaque directly on the cast to UCLA abutment. Here's an example from Dr. De Oliveira where he had the lab cast a UCLA abutment, put ceramics directly on the custom abutment, then cement a ceramic crown over that UCLA abutment. But it's just not done much anymore, the old casting to the gold cylinders. Most of them are done CAD-CAM, so we have a custom abutment that is CAD-CAM machined. It turns out to be less expensive and more precise. So there's been a big fall off in the use of the gold cast to UCLA abutments nowadays. But you can see the emergence profile, how that's improved on the custom abutments, okay, as opposed to a stock abutment. This on the right would be a stock abutment with a kind of a symmetrical margin, just a round stock abutment. But you can see their emergence profile isn't really just a little round hole. You can see on anterior it's kind of triangular, on bicuspids kind of oval shape, kind of square, and the posteriors, so that emergence profile can be customized with a custom abutment. So here's another example from Dr. De Oliveira actual case where it had kind of a pretty tall vertical that was too tall for a custom abutment, and a really fairly short on the gingival. So the implants are close to the gum line but had a tall vertical. So we sent this out for a custom abutment, which are machined here. So you can see the custom CAD-CAM abutments are machined from this pre-machined block. So the block, titanium alloy, is pre-machined with the same exact tolerances as the stock abutments and turned into a custom abutment. And so we'll see how that goes here with this video. And all of these videos are available at implantdirect.com. We have over 100 videos there. So you can see on this case, the blank, they call these a blank, has a pre-machined interface with the same exact tight tolerances to the implant. So the software is uploaded to the CAD/CAM machine, and so that machines that design out of the blank. So it's like making a little sculpture, so it's a reduction process, like chipping a little sculpture out of the block. So you can see how these kind of anatomically contoured margin is exactly controlled, because interproximal, it's the margins are a lot higher on the interproximals. So that's completely controlled for a nice emergence aesthetic result. So here we are at chair side. So you can see how the ferrule length and diameter and contour was all maximized. And you can tell this was a guided case because the screws are coming right up through the centers of the abutments. And so with controlling the ferrule height of the abutments gives a nice even layer for the height of the ceramics fitting over the abutments for a final result. So here's another analog sculpture, just sculpting out of a block. So on the form that's sent to Custom Direct, it's usually sent by the lab, but where they'll check off on how you want the margins, if you want the margins at the gum line, if you want them, say, subgingival on the facial, maybe at the gum line on the lingual, or if you want it subgingival all the way around. Okay, also if you want any flare to the custom abutments. Okay, if you didn't use a flared transfer, or if you didn't use a customized impression transfer, they can, with the soft tissue model at Custom Direct, kind of make a flare to the abutments if desired. Okay, when you get up to this much flare, say on the right, you would probably have to numb the tissue to get this much of a flare of abutment in. But those are two of the kind of the checkoffs when the form is sent in. And a preview of the abutments is sent either to you or the lab before the abutment is machined. And it's usually a 3-day turnaround. You just have to reply back after you look at the 3D preview that is sent. It's a PDF, but it's a 3D PDF that you can roll around and see in different orientations. And then when you OK that, then they go ahead and machine it for the 3-day turnaround. So you can see in this case, it was kind of the opposite of the previous case shown. This one has a shorter vertical, so but with a deep tissue. So this one has a deep tissue with a shorter vertical occlusally. So you can see the actual tissue depth is deeper than the abutment height. Okay, so you can pretty much only do that with a custom abutment. So these margins, as you can see on this custom abutment, are exactly controlled at the gum line. Okay, but here's again a custom abutment for a screw retain crown, example from Dr. Monk. Again, where this was a custom abutment, and then you can decide, do you want to go ahead and let the lab go ahead and cement this in the lab, or do you want to first try in your contacts, and then cement it with the composite resin cement. Then here's an example from Dr. White. Again, he's one of the he lectures at our 102 aesthetic course where we have the hands-on, and he also teaches at UNLV, and all of the abutments that he does in his actual private case here in Las Vegas are custom abutments. So he doesn't use any stock abutments. Everything's customized. You can see how all these margins are always customized. And then he has an Emax crown that will be cemented over the abutment, but he asked his lab to anodize the abutments. So the abutments are actually gold anodized. Can't see it very well in this example. You can see it a little better here. It looks really nice. So you can ask your lab to anodize the abutments, and Custom Direct will later this year, they will offer that service where you can have the titanium alloy abutments actually anodized. So when they come to your office, they're actually gold anodized. Very nice result. Again, the result now, the preference is very commonly now for the screw-retained crowns. Well, you torque that down to 30 newtons, say, and some doctors actually have the patient bite on a cotton roll for like 5 minutes or so. So torque it down to 30 newtons, have the patient kind of bite on it, chew on a cotton roll a little bit. Then you can torque it again, and you can get the screw to maybe stretch a little bit more when you torque it down again to 30 newtons. Then kind of twist in your Teflon tape, then patch it over with the composite. Okay, so thank you all for your attention, and I imagine now we can go to see if we have any questions. Well, the first question is about the 78 degrees. It depends on how you measure it. As you measure it, yeah, it's 12 degrees measuring from the other side. If you measure from the other side of the angle, 78, right? If you measure from the 90, the other side is 78, measure from the inside to the sidewall is 12. So it's kind of the same. A 12 degrees is the same as a 78 degrees. And then it says, can you show how the technique for making the custom abutment impression? So this is that case where they use the natural tooth around the fixture mount. Okay, so there they took that temporary abutment and then made an impression of that temporary abutment. Okay, then so you now have a little model with an implant analog. You screw down the temporary abutment, inject impression material around that, and now you take the fixture mount that's going to be the transfer, and then you inject the resin or composite around it to make the customized fixture mount. So here we have the fixture mount that's now going to be the customized transfer, I should say. So this will be the customized transfer. So when this is placed in the mouth for the impression, it'll hold the tissue out to that same emergence profile as the natural tooth. And again, we teach this in our 102 aesthetic course. And so you can see that the final restoration has that same platform. And here's show it again in our hands-on, where we do this in the hands-on, make a customized provisional, and then we use this provisional to make the customized transfer, where we take an impression around this provisional, put on a transfer, like an impression transfer, inject composite around it so it has the same emergence profile for the impression. Let's see if we have any more questions. Regarding the anodized, what is the benefit of having the abutment tissue surface anodized? Well, it's just gold, so you don't have any gray show through the tissue. Some tissues are kind of thin and delicate, where the gold just gives a warm hue, so the gold doesn't, like the silver. Silver kind of shows through delicate, thin tissues. The gold doesn't really show through like that, the gold hue. Oh. And there's a question about zirconia custom abutments. Unfortunately, our Custom Direct is not yet making the custom zirconia abutments. Hopefully they will later in the year. We do have these little titanium interfaces where your laboratories can scan them. Your lab can make a zirconia custom abutment and then cement it to they call it tie bases. So they're called tie bases, and they can cement the lab-made custom zirconia abutment to the tie base. As far available from Implant Direct now, we have stock zirconia abutments that are pre-cemented to the tie bases, but Custom Direct does not yet at this time offer a customized zirconia abutment. Okay, here he's asking to get back to the slide showing the pre-cementation where you're using the PVS replica. Okay, this is a kind of a technique to kind of prevent any cement from sneaking under the tissue, where you make take the abutment and the Teflon tape. Oh, here it is. Okay. Okay, so this is where to kind of minimize any excess cement, the possibility of that sneaking under the margins, is you take the custom abutment you have, you put plumber's tape in the crown, you push the custom abutment in the crown, you take the titanium abutment out, so the plumber's tape remains, and the plumber's tape leaves that film thickness for the cement. Okay, so now you have the plumber's tape in the crown. Now you put cement now you remove the plumber's tape, put the cement in the crown, and then place in your little PVS die. Okay, you push in your PVS die into the crown that has the cement, so you can see all this excess cement is wiped away. So now when you remove the PVS die, the cement remains. So you just have a thin layer, the layer the same thickness as the plumber's tape. So you're not going to have this glob of cement kind of sneaking under the margin. See if we have any more questions. Yes, he's asking about, is the interactive abutment compatible with Nobels? It is on 2 of the platforms. We have what they call narrow platform and regular platform. Narrow platform has 3.0 interface. The regular platform has a 3.4 platform interface, so it's compatible with Nobel's narrow platform and regular platform. So I'd like to thank you very much, all the attendees, for my first webinar.